Your urinary tract is a highly calibrated filtration system. Every day, it processes fluids and flushes microscopic minerals through delicate, narrow pathways like the ureter. But occasionally, those dissolved minerals fail to flush out. They concentrate, crystallize, and over time bind together into dense, jagged mineral deposits that get trapped deep inside the kidney. While a typical stone might be 5 millimeters and eventually pass, certain formations escalate into what urologists call a Staghorn calculus. These multi-branched structures can span up to 5 centimeters across, entirely blocking fluid flow and threatening to permanently damage the organ. Historically, removing a solid rock of that size required invasive open surgery, meaning surgeons had to cut through layers of muscle and kidney tissue to reach the stone. The modern engineering challenge is extracting that solid mass without the trauma of a major incision. To address this, urologists utilize a specific decision-making framework, selecting a treatment pathway based on the stone's exact size, density, and location. For straightforward stones under 2 centimeters in size, the first line of defense doesn't involve any internal scopes. It's a procedure called extracorporeal shockwave lithotripsy, or ESWL. A machine positioned outside the body generates high-energy, converging acoustic pulses. These sound waves travel through soft tissues without damaging them. Because the stone is dense and brittle, it cannot absorb the energy of the wave. When the acoustic pulses hit that exact focal point, they create violent vibrations that fracture the stone, shattering it into fragments small enough to pass naturally in the urine. However, sound waves have limitations. Some stone compositions are too hard to crack, and if a stone is sitting in the lower pole of the kidney, gravity often prevents the shattered fragments from flushing out of the system. When indirect physics fails, surgeons must physically enter the plumbing to confront the obstruction at point-blank range. This leads to ureteroscopy, the direct escalation for stones that are too dense for shockwaves, larger than 1 centimeter, or lodged in the lower kidney. In this procedure, the surgeon threads a miniaturized, flexible scope backward through the body's natural pathways. It travels from the urethra, passes through the bladder, and snakes directly up the ureter to reach the kidney pelvis. Once the camera locates the stone, the surgeon feeds a hair-thin laser fiber through the scope until it rests directly against the target. The laser delivers rapid pulses of photothermal energy. This can either dust the stone into microscopic particles or break it into larger extractable chunks. To remove these pieces, surgeons deploy tiny wire baskets out of the scope to ensnare the fragments and drag them safely out of the body. While fiber-optic lasers offer high precision for mid-size threats, truly massive stones require a more direct, heavy-duty mechanical intervention. For the most complex cases, like that 5-centimeter Staghorn calculus, surgeons rely on percutaneous nephrolithotomy, or PCNL. Rather than traveling through the narrow urinary tract, surgeons bypass it entirely. They make a small, direct incision through the patient's back, creating a shortcut straight into the kidney. Through this access point, they insert rigid nephroscopes and ultrasonic tools to mechanically drill into the massive stone and vacuum out the resulting debris. This percutaneous shortcut allows even the largest internal obstructions to be dismantled and cleared without the need for traditional open surgery. After any of these procedures, the urinary tract is often inflamed. The system needs time to heal and a way to flush out any residual stone dust without becoming blocked. To prevent postoperative swelling from blocking drainage, surgeons place a ureteral stent, keeping the pathway open while tissue recovers. But extraction is only the first step. Data shows patients who form one kidney stone have up to a 75% probability of forming another. Because of this risk, care eventually shifts to long-term prevention. Urologists use 24-hour urine collection to analyze a patient's specific chemistry, tailoring diet and hydration plans to prevent new crystals from bonding. While the biological risk of stones remains a recurring challenge, the shift to acoustic shockwaves and laser navigation ensures these obstructions are now managed through precise, minimally invasive logistics.